The topic that I was asked to speak about today is congenital diaphragmatic hernia, and this is something that I've been doing for a long time. I was just talking to Dr. Myers before everybody got on, and I did my fellowship here in the late 90s, and I've been at Children's Hospital of Philadelphia ever since. And congenital diaphragmatic hernia is a relatively rare diagnosis, but it's one that we see quite frequently. So we have 40 to 50 a year. Last year we had over 60. And I must say, we've got an incredible team and an incredible Center for Fetal Diagnosis and Treatment. So we do attract a lot of families who come for, to deliver here and second opinions and such. And the more I see babies with CDH, the more I realize that they're each so different. They each have a very different phenotype. And I think that that's very important because we all the time try to create a checklist and to create rules and algorithms for care, but each baby is so different. So I wanted to, sort of share that with you today, some of my experience, some thoughts, some current thinking that's out there, and try to make it as interesting as I can. And I hope I'm not boring just talking to my screen, so forgive me for that, but hopefully this will be helpful. So I wanted to review the pathophysiology of CDH because you should all know the basics of that, discuss some of the prenatal considerations that are especially important, for the postnatal world that we see them in. Discuss some delivery room details and aspects of the neonatal management. And most important, really critical to all of this is a discussion about pulmonary hypertension and cardiac function, and really the importance of a team approach. So CDH, maybe 2 or 3 per 10,000 live births. Most common is left-sided, about 10% are right. Bilateral in very few cases, which is pretty much lethal. Most common is the Bacteluck hernia, and mortality is anywhere from 25 to 30%. Now, the pathophysiology, we always used to think about it. In the 90s, I learned it as being, they just had small lungs, right? Everything herniated up on one side and their lungs were small. But then we started to realize they were having blue spells, and it wasn't really, was it like a BPD spell where they're turning blue, or is there something more? And so then we really got into looking further at their whole pulmonary vascular tree and realizing that the whole tree is really quite pruned. Very few vessels with a lot of thickening within the vessels themselves, altered vasoreactivity as well. And then more recently, the lungs, the blood vessels, they're all small and different, and both sides too, not just the side with the hernia. But, very recently, a real big focus on the heart and how that's different. The left ventricle is often small, the right ventricle is often very thick, and they can have impaired coronary perfusion. This all happens at, a critical time point way back in the embryonic or, pseudoglandular phase in the embryo, when about 4 to 7 weeks or so, when there's branching of the bronchi and the blood vessels. This is a really very critical time for this difference to be occurring. The arteries and the blood vessels of the CDH baby are muscularized all the way down right to the respiratory units, which is quite different than in the normal situation. And this ends up being very difficult sometimes, right, to get them oxygenated and ventilated. So we say to them, of them that they're obligate shunters. They have to. That's their anatomy. So their pulmonary vascular tree is small and their blood vessels are thick, and so they have to shunt. They use that ductus. So we often see that pre and post ductal split. This paper is a must read. It's one of my favorites. Matt Harding in Texas put it together, and it really discusses the pulmonary hypoplasia, the pulmonary hypertension, and the ventricular dysfunction really nicely. So I put the full reference here. So I definitely recommend you to read this. CDH remains the cause of the most non-cardiac neonatal in-hospital mortality. And I think that that's a really important sentence. And this was just reported out in the Annals of Epidemiology in April of 2021. It's a really big cause of mortality. And, those of us that care for these kids, you try to get them all through, but it really is a significant cause of mortality. And it's the costliest non-cardiac birth defect. So that's very important for us. There's a huge spectrum of disease as well. There's some kids that are minimally affected, and then some kids who just have severe fixed hypoplasia, and it's impossible to oxygenate and ventilate them. Then there's this mixed group in the middle, and with the oscillator and different meds and ECMO, survival has really improved in that middle group. And it's the most severe group in the far left. Those are the candidates that there are different fetal and prenatal interventions that are attractive to try to alter the natural history of disease even before they deliver. So this is, a little bit of my work, just because I have my own numbers, but this really reflects what the rest of the country is seeing as well. So we're also part of a CDH focus group through CHNC. And this is what a lot of the centers are reporting as well. Survival in CDH has improved over time. And really what's done it's been the kids with their liver up. So the liver down kids, you can sort of see a static survival curve here. But with liver up, some of the details that we've done, some of the changes that we've made over the years do seem to be making a difference. And as related to that, ECMO rates have also decreased over time. So really about ECMO, in some big centers, about 25% of their kids will go on. So really, what makes a difference? And I must say, this is huge. It's a team effort, and it really starts with the prenatal workup, getting all the T's crossed and the I's dotted. You got to know every single thing about that fetus and that baby before delivery. You have to be ready. The first hour counts, and then every little detail in the ICU, including surgery, makes a big deal. Prior to their, first discharge and launching out into follow-up programs and beyond. So this is just a really important thing. You can't be one really good person. You need an extended team. I can't underestimate that. What about prenatal predictors of outcome? Are there any things that really stand out? Well, people think the LHR and the liver position, right? Like that's the where we all go to in our heads, but really you need to look at, is there some genetic difference? Is there any evidence that the baby might have a syndrome? Because that has a huge impact in addition to size of lung, et cetera. And does that baby have any cardiac disease? And then of course, liver position and lung size. So about 60% of kids with CDH have an isolated presentation, whereas CDH is the only apparent major malformation. In about 40%, we say they're like CDH plus. So they may have an additional structural anomaly or a syndrome or some genetic difference. Prenatally, a microarray is now standard of care. If there are multiple anomalies, a lot of places will send a whole exome sequence, and whole genome sequencing is kind of research right now, but being discussed on the horizon. So really looking for chromosomal abnormalities, copy number variants, microdeletions, or single gene mutations. Other anomalies that are common: cardiac, VSDs, ASDs, and TETs. In the CNS category, neural tube defects and hydrocephalus, and musculoskeletal, so limb abnormalities, polydactyly, syndactyly, and some limb reduction defects. Of the syndromes, the most common aneuploidies are trisomy 13, 18, 21, and 45X. The most common copy number variant is Pallister-Killian, And I'll just say a few words on that because that comes up a fair amount. So that's extra copies of the short arm of 12p. So CDH plus this very typical facial appearance. And I know genetics is always looking at the temporal lobe baldness, that frontoparietal sparseness of hair. They have widely set eyes and a very hypotonic face, eversion of that lower lip, and the difference in their upper lip with the philtral skin. They may also have helical ear pits, umbilical hernias, duplicated thumbs, some swirly hyperpigmentations of the skin, and supernumerary nipples. The other is Fryns syndrome, and that's the most frequently diagnosed syndrome. And if you Google search Fryns syndrome, this is a picture of the little girl that comes up. You see very coarse faces, a broad forehead, and they're classic to have CDH plus coarse face and the hypoplastic nails. So if you see that, always think Fryns syndrome. And this is thought to be autosomal recessive. So the other big piece of it is cardiac. So all pregnancies with a diaphragmatic hernia should have an echocardiogram. It really is the most frequent associated anomaly. In a group that we looked at, we can see here, those infants with congenital heart disease, really their survival rate drops significantly from those with congenital heart disease. So the risk of death is about 3 times higher. If you look at the data that's been reported to ELSO, VSDs, coarcts, and hypoplas most common, and the overall survival in that group's 47%. There was another really good review in Journal of Pediatric Surgery in 2019, a CDH and heart disease systematic review, looking at thousands of infants, and they found that 17% of them had an associated congenital heart disease, and the ECMO was in a third of them, and for those with critical heart disease, survival was 32%. So this has big impacts for trying to get an accurate prenatal diagnosis, trying to decide are they fetal candidate, ECMO candidate, and such. So really a very detailed prenatal echo is critical, and that impacts what you do postnatally. Another thing that is widely talked about is liver position and lung size. And, postnatal survival is thought to be directly related to LHR, and that's done by ultrasound. More recently, fetal MRI has been done looking at total lung volumes and stomach position, and that's also been helpful in terms of prognosis. A little bit more about that LHR. It's something that we say all the time, but what is it? So the LHR is calculated by dividing the two-dimensional area of the contralateral lung taken at the level of the four-chamber view of the heart by the head circumference. And traditionally, an LHR of less than 1 is thought to be a predictor of poor outcomes. But this original description, which was done at UCSF, was published in '96, and it looked at fetuses 24 to 26 weeks. So the original description did not take the gestational age into consideration. So if you have mom coming through your doors at 30 weeks, that you get an LHR number, what does that mean? So something new has been created. You may hear the O to E LHR, and that's really to correct for gestational age. So now the LHR is expressed as a percentage of what can be expected in a normal fetus. So that's the O to E LHR. And so we say they're in an extreme category if it's less than 15%, severe if it's 15 to 25%, and that number is important, severe, less than 25%. And that's the same for O to E LHR and the MRI total lung volume. And that number, 25%, comes up again when we look at fetal interventions. So that number is important. And then I would be amiss to not, mention the kids with a postnatal diagnosis. And, most of us in big centers, we see all the prenatal diagnoses, and then a couple postnatal slip in and you barely remember them. But, before everybody got on the line, I was talking to Dr. Myers, and this is a question on the MoCaPeds board review. And, you have a patient that comes in and is tachypnic and retracting, heart rate of 180 and blue, SATs in the low 80s. What's the first thing you do? And the correct answer is place an NG tube, which I'm not sure I agree with, but needless to say, I did get the question wrong, which I feel really bad about. But that is what you do. And to me, you'd get a chest X-ray, you'd put them on oxygen, and the like, and yeah, of course, place a sump to suction after that. And this happens, about 40% of the time is what the literature says, which does seem high, but that's what it says. So then let's look at, so we'll turn again away from postnatal diagnosis. What about prenatal intervention? Is there anything that can be done to make outcomes better? And, there's been a long history of fetal surgery for CDH. It started way back in the 90s with Dr. Adzik doing anatomical repairs. Then there was work done putting tracheal clips, and then which moved on to fetoscopic tracheal occlusion with balloons, and then the total trials in 2008. And total stands for tracheal occlusion to accelerate lung growth. And the way this is done fetoscopically, it is just incredible if this even works. The baby has a balloon placed into the trachea while they're in the amniotic fluid floating around. I mean, this is just nothing short of a miracle to me. It's crazy. So this balloon is placed, and then they pull out. The uterus is not opened. It's all done fetoscopically. Okay. And then what does that balloon look like? In the airway, you can see the balloon with the little end bit. So this is what it looks like when it needs to be removed. So the total trials were done with isolated left CDH in kids in that severe category that we mentioned, ODE LHR less than 25%. And the balloons were inserted between 27 and 29 and 6/7 weeks, removed 34 and 6/7 weeks, and then standard NICU care after that. The thought was that by placing that balloon, the normal egress of lung fluid would be prevented, and thus there would be parenchymal lung growth that would include the alveoli and the blood vessels. And we do know that prolonged occlusion reduces the type 2 pneumocytes, so then they can have surfactant deficiency. So for babies that deliver very soon after having the plug removed, then they would need surfactant right away. Otherwise, if the tracheal occlusion is removed and they have at least 48 hours, it seems like they have normalization of their type 2 pneumocytes. This was just reported in the New England Journal of Medicine, so another very important reference. So I put the full reference there at the bottom. And what was the conclusion of this was that the use of feto in fetuses with isolated severe congenital diaphragmatic hernia on the left side resulted in increased survival to hospital discharge, but also an increased risk of preterm labor, preterm rupture of membranes, and preterm birth. And if you see here, if you go up to the top, so surviving to discharge, it was very significant. But then the expectant care group was only 15%. And I think that's where we are struggling in North America, because these are not our numbers. We, in fact, many places have survival rates of 60 to 80+% in that group. So there's a lot of discussion right now within NAFNAT as to how to move forward with this work. Now, we have also done 10 cases, and that was a requirement to do pilots so that people would gain experience. Jan Deprest went to places and was very good at teaching people how to place this balloon. And now we are ready to go, depending on what happens after the New England Journal paper. But suffice it to say that our survival was not impacted. Like that's, our survival was the same. But what we did see, which is really incredible, and so more to come, you'll be hearing more about this down the road. We saw a much lower rate of ECMO, and we had lower pulmonary hypertension. We had no kids go home on pulmonary hypertension meds, whereas in our traditional severe group, 60% do. We actually had less respiratory supported discharge and a decreased length of stay. So the trial is incredibly interesting with the outcome, but but what we have found is quite different, if that makes sense, but equally as exciting. So now we'll just move into early management. So these are kids, feto or no feto. Early management. You meet a baby, and this is the typical look from the side, a very scaphoid abdomen, because there's bowel, liver, stomach. There's all the organs up in the chest. They have this very typical scaphoid look to them. Immediately we intubate them. We start oxygen around 50% with aiming for a goal preductal oxygen saturation of greater than 85%, because that's what the brain is experiencing. And then very gentle ventilation, allowing the CO2s to be high, 50s, 60s, and then really approaching them with small breaths, rapid rate. It's really important to get an x-ray right away because anecdotally we all know that with that mediastinal shift and contents up in the chest, you can't expect the carina to be where it is in a patient without a CDH. And this was a really nice paper by Jason Geen in Colorado. And what they found was that in CDH kids, the carina was cephalad. And so they recommended adjusting the depth of the ET tube by 0.5 centimeter. And so what we do is intubate them and then obtain an immediate chest x-ray, knowing that they do have some structural differences, and just making sure that it's in the right place. You don't want it too high, then they won't ventilate and they're at risk for extubation. And you also don't want it too low. That affects gas exchange and they can develop a right-sided pneumothorax. We do place lines straight away, a UAC. We often say a low UVC. When the liver is up in the chest, it is really hard to tell if your UVC on x-ray is in the right place. And success rates are anywhere from 10 to 20%, to be honest, even with ultrasound to look to see where that is. So low UVC for resuscitation, peripheral venous line, and then oftentimes early PICC placement once they're stabilized in the unit. Again, you can see, the carina can be just about anywhere, and you really need to make sure your ET tube's in the right place. And then with everything shifted and hazy, hard to see where that UVC is. Okay, so now let's say.
Chat. And the question is, do you start on early high frequency jet ventilation?
Well, that's a great question. So that might be my next slide. So hold up just 1 second and let me see if I get to that. So this is a picture I just took of one of our patients, just a screenshot. This is very typical early on to see that ductal split. So pre-ductal 93, post 71. So here, let's just say this little baby that you're resuscitating, the first gas, hypercarbia, the CO2 is only, or the PO2 is 34, there's a base deficit. What do you want to do? You have to really pay attention to the respiratory management, the blood pressure, and also sedation. And then once you do that, still a little bit of hypercarbia, metabolic acidosis, small lungs, shunting, and now the blood pressure is a little bit low. So going back to this, what's really important in the delivery room or even in the first few hours, and maybe this will address the question that just came up, is really trying to find that sweet spot. You don't want to be too inflated and you don't want to be underinflated, because both of those extremes increase your pulmonary vascular resistance. So oftentimes, if they're liver down, starting with conventional mechanical ventilation. Something like 25/5 with a rapid rate does the trick. But if there's a lot of liver up, that's not going to work. You're not going to be able to ventilate that patient. So then we'll often start with high frequency oscillatory ventilation. So not the jet, but just the oscillator with a lower mean. Adjust the amplitude to wiggle, but it's often in the 30s, and hertz of 6 to 8, and an early blood gas. Okay, I think that answers the question. Is that good? There was a trial that's very important for everybody to know, the Vichy trial, and this was done, randomized clinical trial done in Europe, looking at initial conventional mechanical ventilatory settings versus initial oscillatory settings, and they found no statistically significant difference in mortality or BPD between the two groups. But they did note a shorter ventilation time and lesser need for ECMO in the conventional setting group. But I often wonder about this because, I mean, it was an excellent study and they randomized kids. I mean, it was just incredible. But I don't know about the oscillator setting. So a mean of 13 to 17 and a hertz of 10 to 12. It just doesn't feel like what we have found works. So while I appreciate this paper, it didn't really change our use. It didn't put us off. So we tend to use the oscillator with lower settings and a lower hertz. And again, knowing these kids, it's not just about the size of the lungs and trying to find their sweet spot. It's also about not making them worse. I mean, we know just based on their anatomy that they're obligate shunters. They do have pulmonary hypertension. And certainly if they get acidotic or their PO2s start to drop, then that is like a combined effect and that will increase their PVR. So you have to be careful. We do treat babies with left-sided CDH and right-sided CDH the same, essentially, very similar approach. And we know that even in both types, they have, as we've mentioned, decreased alveolarization, hypermuscularization of the vessels, that decreased cross-sectional area, and altered vasoreactivity. And in addition, the heart is displaced in utero by the herniated abdominal organs, which causes altered ductus venosus flow with preferential streaming to the right atrium and chronic underfilling of the left ventricle. And this is thought to potentially contribute to LV hypoplasia. So what do you see on the echocardiogram in kids with pulmonary hypertension? Oftentimes the RV systolic pressure is more than the systemic systolic. There may be flattening and bowing of the ventricular septum, tricuspid regurg, and bidirectional or frankly right to left shunting across the PDA. So it's really important on that first echo to look at shunt, especially if you're standing at bedside. It's always really helpful. Shunt at the ductal level and at the atrial level, and also at the ventricular function. Really, really important, right and left. You really need to make note of that. This was also, Jason did this great paper with Dr. Kinsella looking at the implications of atrial level shunting. And left to right atrial level shunting should prompt a closer look at the left ventricle size and function. And sometimes that'll just be hidden in the report. You really have to nail that down. What's happening with the atrial level shunting? So direction of the ductal shunt depends on the difference in the pulmonary vascular resistance and the systemic vascular resistance, but the direction of the atrial shunt is determined by ventricular compliance. And this is really critical. So in this patient that we're taking care of, the echo's complete. The baby's still shunting on 100% oxygen. Next, now what? And this paper, again, I gave you the full review, is by Satyan. This paper is incredible. Another must read. You'll love it. I just love how they've written this up. It's quite excellent. But if we can just sort of break it down, and let's just look at the right upper quadrant for now. So with significant pulmonary hypertension, you want to make sure the lung recruitment is good, and then to consider inhaled pulmonary vasodilators and sildenafil. Some places have IV sildenafil and they start that up. And some places have enteral, and that's for down the road. So I'm not going to talk a whole lot about that. But I did want to mention a few things about nitric oxide, because that is in the pathway for PPHN. But then you might wonder, what about for CDH? It would make sense, right, to protect that right heart. And, if you've heard a talk by Robin Steinhorn, she'll say inhaled nitric oxide was actually named Molecule of the Year in Science Magazine 1999, which I couldn't believe I didn't know before, but this is true. So, it's great, right? It's a selective dilator. It's a decentralized therapy used in every unit. We all have it. And it's the only FDA approved specific pulmonary vasodilator. So, maybe you should just start it on all of them if they're shunting. But no, you have to really think about this. And there have been several papers written that have really said nitric oxide is not indicated in CDH. And that Ninos paper in 97 did show that there were some responders in the CDH group, but globally increased ECMO. So the conclusion was no. The CDH registry, they didn't really comment on cardiac function. And in fact, many kids were started on it without meeting criteria for pulmonary hypertension. So I'm not sure about their conclusions. And then the Cochrane review looked at all sorts of papers that, don't really reflect our contemporary treatment of CDH. Another important thing that Dr. Steinhorn has written about is, being very careful about how much oxygen we use. In addition, hyperoxic ventilation increases oxidant stress and lung injury, and it may paradoxically impair the vasodilator response to nitric oxide. So again, a lot of the papers that were written, people used to just start with 100% oxygen right from the minute they were intubated. So now that we've scaled back, starting with 50%, even some places 30%, we need to relook at this. The other thing is that, when you really break it out, now we did a contemporary review, so I'll share some of our numbers. When you break it out and you look at the echo, okay, so overall we had 40% responders, which is significant. Who were the non-responders? Well, they were more likely to have left ventricular systolic dysfunction on echo. And of the responders, we found that they were less likely to require ECMO. And so this is a contemporary cohort. So I want you to open your eyes about nitric oxide and to consider it. In fact, guidelines from the American Heart Association and American Thoracic Society and the Canadian CDH Collaborative, in their reports, they've said that inhaled nitric oxide is indicated for confirmed suprasystemic pulmonary arterial hypertension without LV dysfunction. Of course, providing lung recruitment is adequate. So to consider that, okay? Now we go back to Satyan's paper, and then we look in the right lower quadrant. So we mentioned LV dysfunction, right? LV dysfunction, starting nitric oxide may actually make that situation worse by developing pulmonary venous hypertension and decreased systemic blood flow. So you have to be very careful. It's very important to know about that left ventricle. And then the other drug, when the left side is down, is milrinone. And so currently in the Neonatal Research Network, there is a trial, and Satyan's leading that, a double-blind randomized controlled pilot trial looking at milrinone in term babies with CDH and looking at their PaO2 in conjunction with other vasodilators. So they're still recruiting. We talked to them a couple days ago. They don't have any results just yet. So more to come. You definitely will hear more about that in the future. Okay, so back to our little patient that's shunting. I just worked on this with one of my fellows, Felix. So it's in press. So anyways, it's out there. It's hopefully going to be published soon. Looking at early pulmonary hypertension and then just breaking it down, like just thinking about it in CDH, breaking it up. Do they have LV dysfunction? Do they have right ventricular dysfunction? And certainly if the RV is struggling, it's big, it's thick, starting some low dose dopamine and some prostaglandin to keep the ductus open as a pop off is a great idea. I'm not going to say much about vasopressin because I don't have a lot of time, but suffice it to say, low dose dopa, prostin, and then a nitric trial as long as the LV looks okay. Now, if there's severe LV dysfunction, we're recommending starting low-dose epi and low-dose dopamine. If there's no hypotension, milrinone is okay, but if there is hypotension, it sometimes makes the situation worse. So if there's no response to this and there's persistent severe LV dysfunction, these are the kids that often end up going on ECMO. If it's mild to moderate and the heart starts to heal, then, and only then, might a trial of nitric be helpful, but always watching for pulmonary edema. We're saying low dose. We used to, in the olden days, drive the dopamine up to 20, 30, thinking that neonatal receptors are all different. You don't know how many receptors they have, just titrate to effect. But in fact, it may be making things worse. There may be, enough pulmonary vascular effects that's really not the right strategy. So we say low dose. And we know from the work, Neil Patel, he's in Glasgow. He also is a great author to look up if you're interested in this topic. He writes very eloquently. And if you ever have the chance to hear him give a talk, you should. He's amazing. So what they looked at was ventricular dysfunction. And certainly as, normal, then RV, then LV, then combined. As soon as you start getting combined LV-RV dysfunction, those are the kids where their survival is much lower. And so here, if we take this situation, this child is maxed out on everything and still with a base deficit and still a little bit hypercarbic, biventricular dysfunction on echo, this might be the child you might say, should we consider ECMO? So if you're not able to maintain preductal sats greater than 85%, and if you have a UAC in your postductal PI2s, in the 20s, you're going to develop metabolic acidosis. It's not enough. Or if there's a rising lactate, or if you feel like you really need high pressures, high pressures on a conventional ventilator, with big tidal volumes, with an elevated mean airway pressure on an oscillator. I mean, sometimes that feels good in the moment, but it just tears everything apart and it's not going to work. It's not a sustainable situation. So once you get there, you should start really thinking about ECMO. Or, you've got other kids who really have what seems to be pressor-resistant hypotension. You're on multiple cocktails, you've added hydrocortisone in the background, and then you're still needing to give them 5 to 10 ml per kilo boluses of saline just to keep their blood pressure in the right range. And of course, severe LV dysfunction not responding to medical management. These are the kids that we talk about for ECMO. And certainly in the olden days, I mean, even up to like a year or two ago, we said 34 weeks was the ultimate cutoff. But with all the total work, there were kids that delivered earlier than 34 weeks, and there were kids that were placed on ECMO, and there were survivors. So we've had a lot of discussions in the neonatal ECMO world about that 34-week mark, and certainly 34 to 36 weeks, that late preterm, they're at higher risk, no question. But there are some younger kids that if they're dying, it's not wrong to consider it. Really, the most limiting piece of this is that the smallest arterial cannula is an 8 French. So the companies do make a 6 French, but it's just too tiny. You get so much hemolysis with the flow that it's not, it doesn't work. Let's just leave it at that. So 34 weeks and above for sure, 32 to 34 weeks, it has to be considered. You have to get a bunch of people at the bedside. You've got to decide, you've got to talk to the family and counsel them heavily about the risks. And of course, lethal chromosomal abnormalities and severe congenital heart disease really should also be considered contraindications. Over the years, we always say neonatal ECMO cases are dwindling. The adult people are really rising and taking the challenge. And even at the ELSO meeting, if you were at that, it's usually in the fall, and it's another great meeting. But it's all loads and loads of adult talks now, and neonatal and pediatric are more breakout sessions. And so we've gotten so good at what we do that neonatal ECMO is on the decline. But what's interesting is that in this teal color, you can see CDH. These numbers have remained essentially the same over time. So that's important. And then, of the kids that go on ECMO who have CDH, we say to families, the ELSO data, this international registry, says of those that go on, about half survive. And that's really important to talk to families about that, because they get on ECMO and, you just, how are they? Well, they're stable on ECMO, and everybody just feels like it's just a week or 2 or 3, and then they're coming off. But in fact, half survive. So now you know all of this, and you've spoken to the family and decided to proceed. The surgeons or team their bedside, and they proceed for VA ECMO cannulation. Now, this is the most common way of cannulating for CDH, is by veno-arterial. Some places will do VV, but again, a lot of times the right heart is the problem. So then some places will leave something around the artery in case they need to convert. And so that's, sort of a judgment call as to VV and VA. And honestly, the past few years where we haven't had that VV origin cannula, it's not been possible, because with the mediastinal shift, there has been no way really to get that Avalon down deep into the IVC. I'm sure there are some cases, and maybe you've seen, but I mean, it really has been pretty much VA for the past few years. So you can see patients on VA cannula in place. And then, you just look at our circuits, and there's so much tubing and tubing and tubing. So kids often take on a big surge response, and then it takes, a little bit for them to open up. But we do know from Neil Patel's group that the LV function typically improves over the first 3 days of life. So if you can be careful with the fluids, try to scuff them, or CRRT or Lasix, try to get their fluid management under control, the LV function starts to improve in the first few days. You can re-recruit the lungs. The average length of time on ECMO in the ELSO registry is 14 days, 2 weeks. Now, there have been other reports of longer, and David Kays in Florida did a review, and the survival really fell off after 4 weeks, and there were very few survivors out to 5. And we have had some kids collectively across the country that have survived at 6 weeks, but in that case, you're not trying to open up the lungs. I mean, the lungs are small, and you're not putting a patient on to grow lungs. They're really going on to, because lungs grow and grow for the first 3 years. You're really trying to get them over that pulmonary hypertension phase of sorts. And so kids that come off at 6 weeks and that survive, they are on multiple meds and really very, very brittle. So let's say your patient is there, and they're doing quite well on ECMO, looking around, they're nice and slim without a lot of edema, and they still can't come off. So this is an example of severe TR. So let's say every time you turn the flow on, you just see this terrible tricuspid regurg. You might say, how long? How long do we wait? And Dr. Hedrick, my very close colleague, who is the head of the pulmonary hypoplasia program here, and just an incredible surgeon, she's always saying, well, time is medicine, right? Time is very good medicine. And sometimes, honestly, just waiting another week is all it takes. But sometimes that's not enough. And sometimes the tidal volume will be low, they'll sound all wet and coarse, and then you'll wonder, what if we take the liver down? What if we do surgery on ECMO? Would that help them as well? So what next? So there are situations where we really feel like, the lungs are relatively open, but every time we turn down, it's the shunting and the TR, and it's pulmonary hypertension. And so in those kids, a lot of places now are starting to use Remodulin early. And there is a clinical trial of Remodulin that is in the works right now, so more to come on that. We did a review of kids with severe pulmonary hypertension with Remodulin, and we did see a drop in the BNP and an improvement in their echo pH severity. So we were convinced, and we didn't really have any complications. So we have become more aggressive with Remodulin, treprostinil, and starting to use it earlier and earlier. The only problem is it takes a few days to get up, so it's not a good rescue med, but we are using it more and more. And we're just looking at reviewing our last 50 cases, so we'll put that out in the literature soon. The other thing is surgical repair of CDH. And I just wanted to mention this. It's not, and so I put it in the ECMO section, but it's, whether you've got a patient who's on ECMO and you're trying to come off and they can't, we consider it. But a lot of times, once you take care of all the other details, the babies can come off and get their repair off ECMO. Or, they're severe and there's a lot of liver up, flow is impaired, it's hard to get the cannula in. Surgical repair may happen very early after going on. Or, just for the baby who's not on, we usually choose to repair it once their pulmonary hypertension is melting away. I mean, if you turn the lights on in the room or you just walk past them and they're shunting 85 over 40, that's not a good time to launch into a repair. And, that was done years and years ago, and they had a high incidence of post-repair need for ECMO. So really respecting the disease and waiting for that pulmonary hypertension to melt away is very important. We find it's also important not to move them to another location. So we do the repairs at bedside. Many kids will have a Gore-Tex patch or need some sort of a patch because they have a big defect. So that can be done with Gore-Tex or muscle flap. And Utah was very ahead of the curve. They were the ones that said, a muscle flap is the way to go. There's no foreign body, and it can actually be done even in the big diaphragm. So we've been doing that a lot lately as well. So again, we mentioned at the beginning of the talk that Freeman of Bochdalek is the most common, the big defects in the back. The Morgagni in the front, they don't impact the lung growth as much. So that's important to know. So in the surgery, the surgeons will reduce the herniated bowel, liver, spleen, stomach, whatever's up there. They'll mobilize the diaphragmatic rim as much as possible, and then assess the defect for the type of repair. And you'll hear your surgeons talk about type of defect, A through D. A's are small, all surrounded by muscle, easy primary repair. The difference between B and C is how much of the area has no diaphragmatic tissue. So we break it down less than 50% and more. And then type D, they're the biggest, and there's almost no diaphragm. So your surgeons will say they have to sew whatever they're putting in straight, oftentimes to the chest wall, even to the ribs. And let's just see, whoops, if I can play this. This is Dr. Hedrick putting in a patch. And I don't know if everybody has seen this and how close you've been to see it. So I thought I would include it. And it's just incredibly tedious work. You can see that they've assessed the size of the defect and all these sutures all around. Then they tuck it in. Okay, so then it's all sutured in one by one by one all the way around. So it's just a meticulous surgery. So, and now that's mainly we've been talking about the acute phase, looking at the ventricles, the right and the left, and that acute transition and also repair. So that's, the acute early transition, but then what about the subacute and the chronic? And really the most important thing to know here is that treatment changes over time. That is for sure. And this is also another nice paper, Jason Geen and Dr. Kinsella. And drug treatment is also, this is also a very good read. Kate Abbotable wrote this, and the currently approved pulmonary hypertension therapies impact one of three endothelial-based pathways: the nitric oxide system, prostacyclin, or endothelin. Okay, so these are the pathways that you're manipulating as time goes on. That post-acute phase for kids who have symptomatic pulmonary hypertension, I mentioned sildenafil before, This is common to use in that subacute phase. It's an enteral drug, as is bosentan. And which drug is used, or sometimes both drugs are used. Sometimes one causes more reflux, so there's a little bit of a difference. But again, working with your pulmonary hypertension team in cardiology is incredibly important to kind of choose the right drug. And we do know that kids with diaphragmatic hernia, those that have higher plasma endothelin levels have poor outcome and more severe pH. So this is, it makes the the bosentan drug quite attractive when you see data like this. So that is used on occasion for these kids. And you might say, well, do we care if their lungs are growing? They've got some pulmonary hypertension. Does it matter? And this paper by Peter Dillon, this is JPS 2004. This paper was it really hit me, and I think it's a very important paper because in their kids, they showed that those that had severe pulmonary hypertension that didn't resolve by 6 weeks of life, they had no survivors. That was only 2004. So pulmonary hypertension is significant, and it's not even something we even talked about in the 90s. And I just find it so interesting over 20 years to have seen how we've moved from lung to vessels and heart. Anyway, so respect the pulmonary hypertension and all the drugs that we have, so many drugs. You really have to try to come up with some sort of an algorithm that makes sense, and you can't do it alone. You really need a strong team to help you with this in terms of cardiology as well. Okay, so I hope this is funny. I can't see anybody's face, but anyways, we really are doing so many things now. We have kids with tracheostomies, PDA stents. We're sending kids home on multiple pH medications, including subcutaneous Remodulin, bosentan, sildenafil, multiple diuretics. We really have to keep in mind this is a severe birth defect, and the right ventricle is not normal. It's doing a lot of exercise against that, that the whole intrathoracic cavity, which is so different. And really just put it in perspective, we don't know what adolescence is going to bring when they launch into their somatic growth spurt and they have this limited vascular bed. And what about as they get older and they move into the third decade? Will the right ventricle be able to hold up forever? And, this brings into the whole question about lung transplant, and not very many, but there are some kids and some patients where this is being discussed now. So this is more to come in the future. So again, I can't stress it enough. A multidisciplinary, interprofessional team is so important to get these kids from the prenatal diagnosis through discharge, through kindergarten, through adolescence and beyond. And they're so phenotypically different. You can't have check boxes and algorithms because each one of them is so unique in their own way. It's really important to respect that. Oh boy, there's a lot here. So anyways, a long and winding road. This is Dr. Hedrick's slide that I borrowed. And, to try to get them through that long-term follow-up, you really need a comprehensive team that knows them in the NICU and then to follow them up beyond. Because there are complications. And we mentioned that, the pulmonary hypertension needs long-term follow-up. Respiratory, they can have chronic lung disease, reactive airway disease, recurrent infections, have trouble with exercise tolerance. They're at risk for recurrent herniation, especially with patch infections. They may have chest wall deformities, pectus, and importantly, scoliosis. Reflux is a big issue. Failure to thrive. Gosh, some of them need 140 calories per kilo and they're still not gaining weight. And then reflux, do you treat them with post-pyloric feeds for a while to try to protect the lungs? The lungs are growing for those first 3 years. You just don't want them refluxing in addition. And then, how many of them need Nissen fundoplications? There was a recent review that quoted almost a third of them require that. So that's a big deal. And, they're at risk for small bowel obstruction. They're also at risk for developmental delay and for hearing loss. And there have been some good papers written about that. So if they've passed their hearing screen in the NICU, that means nothing. They need recurrent screens to look for that. This is work Dr. Hedrick in the PHP program did, and looking at their neurocognitive results. And I mean, overall, this is sort of a nice distribution, with most of them ending up, being pretty average. So that's good. And again, that approach as a team and observations. I think back, this one story kind of sat with me, and we talk now all about liver up. Is it liver up, liver down? It's like major fork in the road. But in fact, that was the whole thing with, liver up being, a significant piece of the morbidity, and that being a big player in terms of who these kids are. That was an observation by a nurse at UCSF caring for these kids early on. She just said, it just seems like a lot of the kids that have liver up do worse. And then suddenly it just changed the whole path forward. So I just encourage all of you to just keep your eyes open. Don't accept anything. Always be questioning, and you might find something that's really, really important. And he's getting them from here to there. I mean, that's our goal, right, as neonatologists, but respecting all the other team players that continue to see them beyond, and and learn and listen from everybody, learn what they're seeing in the clinic years down the road, and then we can adjust what we do in the NICU. It's an incredible journey as a team. So that's it for me, Dr. Myers. That's the conclusion of my slides. I know that the team wanted us to present like the upcoming lectures and this QR code, but I'd be happy to take a couple questions if we have a couple minutes, or what do you think? What's best?
That would be great. Thank you so much. It was a great talk. I learned a ton, and thank you for spending your time with our fellows. I have a couple questions. First of all, Patty Chess agrees with you that the mock question wasn't fair.
That makes me feel so good. Thank you.
And I have a couple as direct messages. Could you comment on the choice of 6 versus 8 for initial hertz, given balancing permission hypercapnia in these babies?
Oh, sure. Well, that's why we say 6 to 8. And it really depends on, scouring the prenatal records and just seeing what you think, right? So if it's like, sometimes there's liver tip, but still they're more severe than liver down. Or is it the liver is up, up to the apex? So that's really a judgment call. But sometimes 8 doesn't do it. So if you start with 8 or 7, early gas, super important. I've always found that starting with 6, you never overdo it. And then if all of a sudden you get a gas and their CO2's, in the 40s, then I wean from there. But that's the art of it all, right? So that's why 6 to 8, you just have to say that, I think.
Just a reminder quickly for people to do the QR code or red cap. It really, really helps ONTPD figure out what we need to do next. Could you comment on starting PEEP? Kind of what values would you start a kid with severe CDH on, and would you ever consider PEEPs lower than 5?
Oh, for sure. That's one thing I think we make a mistake on a lot of times. If they're not oxygenating, we start to dial up the PEEP. We treat them like our non-CDH kids. And in reality, they do have just soft, small lungs. They shouldn't really need a lot of PEEP. Now, having said that, sometimes, they come out wet, you put them on the bed, and then you intubate them right away before they've had their first scream and open stuff up. So there is a little bit of recruitment that does need to happen. So starting with a PEEP of 5 is great. But honestly, they'll get more pulmonary blood flow on lower PEEP. So if you're struggling with oxygenation, sometimes the go-to move is to drop the PEEP to 4 or even 3 to give that a try before going up to 6 or 7, because that can affect pulmonary blood flow. So it's looking at that first x-ray, having a listen to them. What's the tidal volume? What is their oxygenation, their whole package, what's happening. So we start with 5 because kind of in the middle, but definitely lower PEEP can improve pulmonary blood flow, and you just have to fiddle around with that. That's a good question.
For an 8 French catheter, very roughly, what is the size of that baby in grams? I think that's probably what was implied in that question.
like in terms of size
Yes.
limits. You know what's interesting about that, and some groups have done ultrasound of the great vessels to see if there's any correlation with the size of the vessel and the weight of the patient, and sometimes not. And I remember one growth retarded baby that was 1.7 kilos, easy to put on ECMO, no trouble whatsoever, great big carotid. And then we had another big fat kid, a couple months out, develop RSV, and we couldn't cannulate. So an 8 French is the smallest we have. And I wouldn't say, this baby's X amount of grams not going to work. It really is something to try. And some places do ultrasound, but some places just open up and take a look. It's part of the consent process, but don't think that if they're small, there's not a direct correlation between weight and vessel size.
Last question, I guess. So VICI was the last really big trial to look at ventilation. And that I think was 2016-ish with some of those papers coming out of some of those reviews coming in or 5 or 6 years before that. Is there anything coming in down the pipeline in terms of big trials that we can get excited for?
Well, I would hope so, but honestly, not really. The CHNC group is doing a write-up on approach to ventilation in CDH kids, but it's sort of a survey of 34 centers across the US. So it's not randomized. It's not looking at any one detail in particular. But that's to come out. We're just working on the final edits before submitting that. And then just going back to the PEEP question, there was a really nice paper written by, and I think it was Laurent Storm. He's in Paris, and he did a really nice, because I didn't really get into DING and delayed cord clamping with CDH and such, and how that affects the heart. But he's done a lot of nice reviews as well, and he's got a nice paper that was a little bit more scientific about the PEEP and looking at low PEEP and high PEEP strategies. So I'd recommend that. But yeah, it's CDH and ventilation and oxygenation and what to choose. It's so tough because it's relatively a rare disease, and we've got so many hospitals. It's hard to study, right? But always the bane of our existence for sure. And then even trying to get optimal lung inflation, optimal FRC, when you can only see that little triangle in the right lower quadrant, right? It is really tricky, but an art, I guess.
Do you have time for a question on about when would you use surfactant? I think that just popped up in the chat.
Well, surfactant for sure. If you have a patient who had FETO, the balloon occlusion, who delivers within 48 hours of the balloon being removed, because then we know with the type 2 pneumocytes, they're going to be surfactant deficient. All other patients, I don't think it's necessary to use it. There have been some young preemies, but even still, you get them intubated and settle them out and then see, because if it plugs up their ventilation at all, and then they get acidotic and that makes their cardiac function, they can tank. So surfactant is sometimes not your friend in that situation, but you have to consider it in the preterm, less than 34 weeker for sure. The older kids, 34 and beyond, I'm not certain they need it. And a lot of places now are also giving betamethasone for the late preterm, early term deliveries. So sometimes you don't even need it. So check with your MFMs and OBs on how they feel about betamethasone prior to, the older kid, the older baby delivering. But in the fetos for sure, and then to consider in the preterms, but the others, not routinely.
Thank you so much. Great talk. Thank you for taking the questions and going a little bit over here. We had over 105 people at one point, which was awesome.
Good. Okay.
And people have stuck around, which means people are interested. So thank you so much.
Well, that's good. It's always fun to talk about this. I do love talking about it, but hard to just talk